Good evening, and welcome to Money Matters. I'm Charlie Huntington, and I am a board member and co-founder of BioStrategy Partners, a 501c3. We're dedicated to helping young, upstart life science companies. Very privileged tonight to have Kimon Hatza as my guest, as my co-host rather. Kimon is with MillCrest Law in Radnor, and your specialties are transactions, and Kimon is a corporate attorney. So welcome, Kimon, and thanks for being here.
My pleasure, Charlie.
I want to remind our viewers that from time to time, financial issues relating to life science or healthcare matters or companies may be discussed on the show. These discussions are not and should be not viewed as financial advice. Moreover, since this program is pre-recorded and shown at a later date, please keep in mind that the information may be dated. You should always check with your financial advisor before entering into any financial transaction. I also want to remind our viewers tonight that they can send questions to be answered on upcoming shows to Money Matters at 205 East Levering Mill Road, Bala Cynwyd, Pennsylvania, 19004, or they can email their questions to moneymatterstv@gmail.com. Kimon, we have the great pleasure tonight of introducing our special guest, Dr. Cheryl Pegus. She received her master's in public health from Columbia University. She has an MD from the Weill Cornell University Medical College in New York. She served as the medical director for the Cardiovascular Risk Factors Group at Pfizer. She was the National Medical Director for Women's Health at Aetna. She was General Manager and Chief Medical Officer for SimCare Personalized Health Solutions, which is a J&J startup company. She was the Chief Medical Officer for Walgreens. Presently, she is the President and member of the board of the American Heart Association's Founders Affiliate. She is Director and Strategic Advisor to Health Fleet Incorporated, an online interactive prevention company. She's a Director of Glytech, which is a glycemic clinical software company. She's a board member at Vision Sciences. She's President of Caluent, a healthcare advisory firm. And perhaps one of her proudest accomplishments is authoring a cookbook with her family, which we will hear more about later. Welcome, Cheryl.
Thank you for having me.
Absolutely.
Thank you, Kimon.
Sure, Cheryl, it's a great pleasure having you this evening. You practiced medicine for 9 years, I believe, and I think you said you're still doing procedures.
Yes.
We've had a couple of people with medical backgrounds on the show previously, and I'm always interested in how you've made the transition from the practice of medicine to the business side of healthcare and life sciences.
Sure. Healthcare is a team sport, and it requires many different players on the field to improve healthcare, not just for the patients that you're taking care of, but also for the country, and even if you're looking at healthcare in a global manner, as I do from a public health background. And on that team, there are physicians taking care of individual patients. There are pharmaceutical and device companies that are developing products, services, pills to help people get better. There are population health managers who are looking at entire communities and trying to make their health better. And there are insurers working with employers to improve the health of employees. So from a physician's perspective, it seemed that getting to understand that entire milieu was really important to be able to do what I like doing, which is improving the health of populations.
What was the most difficult aspect of that transition for you?
I think finding mentors who thought that physicians could do some of the business aspects of healthcare as well as the clinical aspects. I think when I started back in the late 90s, there weren't many physicians who were doing this. And so really, I think kind of forging a path and saying, yes, actually, we do know clinical medicine and we do understand how to improve healthcare and make sure that institutions stay financially viable is something that started. And I think now we're seeing many more physicians obtain MPHs and MBAs. So we're really seeing that blend to stay in the healthcare arena.
Now, you're the president of Caluent. Can you tell us about that company?
Caluent is a healthcare advisory company, as Charlie mentioned, and we work specifically with venture capital firms, and we also assist in some small to large companies. Our sweet spot's probably medium-sized companies, and we do different things with them. So if you think of a small startup, they're really focused on how do we keep getting funded?
Right.
And they really, I think their senior team is really out there trying to meet with investors. A medium-sized company, however, is focused on their product implementation, development. How do we make this a product that adds value within a clinical environment? We go in, and our differentiator is we help them develop that strategy through a business case and through data analytics. And so we are biostatisticians, actuaries, people who've worked not just in the insurance world, but people who've worked in the clinical world. And so we design clinical studies looking, did this company's product improve clinical outcomes for a patient population? Is it impacting patient safety? Can we see cost effectiveness, particularly within an affordable care world? And so we have a niche of skill sets that really allow a company to demonstrate why their products should be in the marketplace, why they're viable, why they should be priced that way. The other thing that we can do based on relationships, we can get them in front of some of these stakeholders to discuss the product and get direct feedback, but also gain entree for sales. So we work with health systems, insurers, retail pharmacies, and really allow our companies to get a depth and perspective so they're building out their execution model.
It's if I may,
Yeah,
it sounds like you're spending your time with game changers as opposed to Me Too's.
We are very selective. We do not work with many companies. You know, one of the things that we focus on is based on the companies that many of us in my group have started or worked with. What are the gaps that we're seeing? So there's a lot of analysis done in seeing where healthcare is going in the future. And we actually provide that as a separate service to some of our venture capital firms as they even evaluate their companies. And we now work with many of them in evaluating companies that they're looking at funding, whether this is something that really adds to it. The world's changed in healthcare. I mean, healthcare cost is something everyone has to think about. But we're asking more of our healthcare companies. We don't need a new product if it's not better than something that's already on the market. And so there's a new realm of medicine called comparative effectiveness. And we do a lot of work in that area for companies who don't understand it and don't really know how to design their products and services to meet those needs.
To fill a need that's not already being filled.
Or if you're going to fill the need, is it better than what's being filled? And you've got to prove that. So not, let's go ahead and pay for that as a product or services for patients to use. Let's prove it first and then go ahead and pay for that. And so we do a lot of that type of data analytics. I'm happy to say some of the people who founded that field work within our companies. So we've been really fortunate to leverage that expertise.
We have a lot of, you had mentioned startup companies and how they're constantly out there looking for funding so they can keep the company going because they're not really viable or operational at that point. And we've seen a lot of venture capital firms that were, historically more active, with startup companies pull back from them a little bit or get involved at a later stage because they're, it's such a long process for those companies. I'm taking it that your companies, the ones that you're focusing on, are really already viable companies. They're operating, and you're looking for ways to make them better, to really take them to the next level.
So that's definitely true, but there are sometimes companies that have a really good innovative product. And so, when we say we're doing a gap analysis, we're really saying, is there a need for a company like this today that could make a difference? And so if you look at mobile health, for example, there are many companies who are, quote unquote, in the mobile health space, but they haven't gone through the process to be a product or service that's actually usable. So have they filed for a 510K? Do they understand the HIPAA requirements? Have they demonstrated that they can be integrated into EMRs? And so there are companies sometimes that are really early who have a product or service that can do that, and we will actually work with them. They just don't know the process of getting it done, and they may be looking for funding. But I think when you meet companies like that, you know, okay, they have something, and we may help build out their management team, even build out their board of directors to really get them on that path so that they can focus on the short-term things they need to achieve to become a medium-sized company. So we do a full analysis up front, but again, we're pretty selective. Obviously, we could not look at many companies. The companies that we work with do a pretty good job of doing an initial screen, and they hire us to come in and do larger screens for them.
May I drill down on something you mentioned earlier, Kimon, and that is, it seems like, I mean, we're a Philadelphia-based show, and it seems like many of the VCs, at least in our area, who did have, and there aren't that many, but who did have a focus on healthcare, we'll call it greater healthcare, biotech, pharma, devices, they've moved on. Are there some VCs, and I guess it helps that in the public markets, many companies were up over 100% if you look at their share prices over the last year, despite the recent volatility. Is this low-hanging fruit for any VC anymore, or is this more the garnish on the plate than the meat and potatoes when it comes to looking at this sector in general? How many VCs are still doing this?
So there are a lot of VCs still in the healthcare space. So they've moved on to mobile health.
Okay.
We're looking at genomics quite a bit, right? You talk about personalized medicine.
Right.
And you're looking for value propositions. So in a world where patient safety, clinical outcomes, reimbursement models, health systems are being dinged if they're not improving on these.
Right.
And so tools and products and services that can fill that space are really, I mean, that's the short term of all of this. If you're able to build out the delivery models of healthcare, you really have focused on a nice niche today. I think historically, biotech companies in the past have focused on a new device or a new pharmaceutical agent. And we would now say, you know, we're moving from just a discovery of new products to the delivery. And I think that's mainly because of healthcare cost, but because we have changing demographics. We have an aging population, a greater need. We've got a lot of products and services that if we could just get them to everyone appropriately, we could really make a huge dent in healthcare. And we're looking at outside the U.S., where internationally countries like India, China are spending greatly on healthcare. So if you're in the investment space in healthcare, you've picked your niche appropriately, and you're not just looking for the newest pill, newest diagnostic delivery, which will come because of genomic medicine, but probably, you know, another wave in 10 to 15 years. Short term now, there are some really necessary products, great valuations that you can really develop and frankly integrate into existing products.
Okay.
Just continuing on that thought then too, a lot of what you seem to be talking about maybe falls into the space that's more like in the software kind of area, like healthcare IT, those kinds of things. And it would seem to be, and tell me if I'm wrong, I don't know where these things fall, like whether they have to go through the kind of FDA review that, you know, pharmaceuticals have to go through, or medical devices, or whether these things, because they're an IT or software type product that helps the delivery of healthcare, really doesn't have that kind of a long process. Am I correct in that?
It's a great question and point. You know, it's why I mentioned before there have been many mobile health companies started. And so late last year, the FDA actually did put out their rulings. And yes, there is a process. You know, we mentioned SimCare before. There wasn't really a process a number of years ago, but if you've worked in healthcare, you understand that if any product is going to be used with patients, that you're going to communicate with them and you're going to tell them to get better. Someone should have oversight of whether it works, be it in the mobile health space or any other space. And so the FDA actually has specific requirements. It's called filing for a 510K. You have to go through clinical usability, clinical validity studies, and for many companies, that's a space they're not even aware of. And I think because the guidelines just came out, But yes, the same models occur. The one thing I will say is that though mobile health is an area and telehealth and software is a good niche, I think, today for many investors, products and services that are having an impact on patient safety. So, can we remind people to take their medications? Can they take it appropriately? Can we decrease infections, which is a growing problem for us? And those aren't necessarily software. Those are more process delivery. And so there are huge opportunities in that space as well. And I think you will continue to see a growth in that, because based on how hospitals are reimbursed through the Affordable Care Act for Medicare, but now also for private insurers, they're being asked to be transparent about those numbers, and they're actually getting dinged in their reimbursement for it, sometimes 5–10% of their reimbursement. Wow. So you're going to see a huge growth in that. So I think there's still a lot of great opportunity in this space, but it requires different skill set than those, I think, who were looking at it many years ago.
I have one additional question on that. Is because the FDA is seeing its oversight is necessary for those types of things, is it having to reconfigure itself internally? Is it having to hire people who have a skill set that the typical FDA regulator didn't have historically because of this new direction of?
And they've been doing that for the last couple of years. I think that's why they finally came out with a position statement of here's what needs to happen because of the proliferation that has occurred. And we'll see it as we transfer into personalized genomic medicine. I think, the evolution of healthcare is the time that we're living in right now. And I think, how do we now take all of these great discoveries that have happened, and frankly, in the last 90 years, and get them delivered to people appropriately, sometimes targeted to them? That's where we are, and the FDA, I believe, is evolving in that direction.
I want to drill down for a minute on genomics. And believe me, I'm no scientist, and our show is geared towards a general audience. So
Sure.
we'll keep
I'll
this high
keep
level,
that,
Cheryl.
yes.
Okay. When I think of genomics, we had a guest on our show, Amber Saltzman, a couple years back. You'll remember her, Kimon. And Amber, basically, her niche is working to change. She's going to come in with a therapy in these patients, and for, let's say, $300,000, she can cure what you have by changing your genetic code? Is that? Now, here's my question. So let's say, hypothetically, I am with one insurance company. We'll call it Insurance Company A this year. Insurance Company A, that is insuring my family and me on the healthcare side, they have no idea whether I'm going to be with them or with my employer, for that matter, for another year. Will they pay $300,000 for this gene therapy, or, and if I even have the right terminology, if it's gene therapy, to fix it, or would they prefer to limp along and pay $30,000 a year for something that may already exist and not cure it? Is that
so, genomic therapy, I think, covers many different aspects. And so just keeping it at a really, I think, high level, what we're saying is that today, if I gave you medicine for hypertension, there is an opportunity for me to actually know if that's going to work in you based on an analysis that I've done. If I know that, I should probably select that and not 4 others to treat you, because they may not work. And so when we talk about personalized therapy, we're actually personalizing it to you, not trying to change your code. We're actually personalizing the treatments to you. And we're really early in the process. And so the things we would want to know, I talked about comparative effectiveness before, and making sure that you're looking at your clinical data in that manner. So 100,000 people who have the same genetic code for that drug, are they all reacting the same way? Decisions to pay for a treatment are based on the fact of whether we can treat, get someone better, if they came back again, would the medicine work again in them? So clinical studies look at comparative effectiveness. We look at validation. And I think once we've done that, we go ahead and say, here's the cost benefit of doing this, looking at just the side effects and other aspects, and then move forward. I think the focus on whether we pay for high-cost treatments, and we've shown that if something treats, cures, we go ahead and do the right thing for our communities and nationally. I think that continues. It's proving that that's actually what's happening. A lot of experimental treatments are sometimes spoken about. It takes years, you know, from a cardiac perspective. Clinical trials for cardiac patients, you know, we're looking at millions, and sometimes you hear people say, well, in 100 patients, this, you know, you need a large population to be able to say this is a treatment that's going to work in everyone. And we're hoping personalized medicine allows us to maybe narrow that down, that this works in everyone with this genetic code.
Okay. Let's change the topic a little bit. As I mentioned earlier, Cheryl, you were the chief medical officer at Walgreens a few years ago. Do you see retail clinics that are springing up in pharmacies and supermarkets as viable options as America sort of rethinks how it does healthcare?
So these businesses have been around now for about 6 or 7 years. So if we look at a business viability perspective, obviously viable. 40% of people in studies who go to retail clinics don't have a doctor. I want to repeat that number, 40% of people.
Wow.
Half of them, if they hadn't gone to a retail clinic, would have gone to the emergency room, even for a sore throat, and I'm talking about adults. I mentioned before, you know, healthcare is a team sport, and so how are we utilizing our teams? If someone goes into a pharmacy and they get, you know, a vaccine from a pharmacist, or they see a nurse practitioner for a sore throat, the way the model is built out is that they're referred to a doctor, and then they're connected to that physician's health system. There's an exchange of electronic medical records between them and the health system. So what we're trying to do is get people into the healthcare system, triage it appropriately, right? If you have a sore throat, it's actually okay to be seen by a nurse practitioner. But for a long-term relationship, yes, you should have a doctor. And that's the model that it's built on, such that today, you know, we talked about how long it's been around. Physicians actually link directly with retail clinics, and they'll sometimes tell their patients, go there, those records will be sent to me, and I'll be able to follow up. So the relationships, I think, that we're saying is you need a multidisciplinary team. You need all players on the field to not only look at the changing demographics, but to make sure we're providing care for everyone. Definitely everyone has a role, but we've got to make sure that checks and balances, that we're making sure people get physicians, so that when they do have a problem, they can access care, that we're doing that. And I think responsibly, that's how the healthcare field is looking at the role of retail clinics.
How many years out are we before, and this is just I imagine it's a guess, I don't know that it's answerable, but how many years out are we before we say, you know what, every person along the continuum, as you put it, all the players on the field need to be able to see Charlie's healthcare records, or we're doing a disservice to Charlie regardless of Charlie's personal rights to privacy? And I mean, where are we with it, and where do you think the puck is going? And
so we're actually, I'd say we've moved the puck, since we're doing sports funds, we've moved the puck down the field quite a bit.
Okay.
And so every patient has access to their personal health information. And we're asking patients to now view their personal health information online. And so you can link into your physician's office, to your health system, and you can see what's occurred. We're also saying to patients, it's really a great idea that your other physicians have access to the data. And so in health systems that have put in an electronic medical record, that's occurring today.
Okay.
And in health systems who are linking their EMRs, be it with a retail clinic, be it with an online health system, that entire visualization is occurring in a HIPAA-protected environment, in an environment where there are a number of privacy rules that are being followed, and that's happening. It's extremely helpful, particularly in the areas of allergies, And I think a lot of people sometimes don't know or understand their allergies, and in making sure that we're not giving people medications that can interact with each other negatively. And Medicare actually already has a program in place to make sure that that information is being shared, particularly so pharmacists can look at it. So some of this is occurring. I think people beginning to know and understand more of it is the consumerism phase that we're entering in healthcare. From a physician perspective, I'd really always like to know my patient's allergies,
Absolutely.
what medications they're
Sure.
on, and if anything has happened before I'm seeing them, I can provide better care within a context than kind of, not knowing the boundaries.
Okay, so with most of these, would most of the players in the health system, and I'm talking about those administering services, so hospitals and doctors, in order for them to be reimbursed today, do they have to share their records? Or some of them are more the mindset, well, everything that's yours is mine and everything that's mine is mine?
So electronic medical records are part of the Affordable Care Act for health systems and for physicians. They've all actually been incentivized to do that.
Okay.
And there are two reasons. One is the patient safety aspect we've just talked about, but we also know that if you know that a patient had, 10 tests the day before, you're not going to reorder them the next day. And so that opportunity exists. And actually there are great incentives for meaningful use. Are you taking the data that's coming in from these medical records and utilizing them across different physicians' profiles to provide the best care and also to make sure you're being cost effective? That's definitely happening. Electronic medical records companies have to make sure that they're not only being certified and recognized for this, but that they're working within that certification model.
It's great, and that probably helps their incentive not to have patients come back then.
Definitely. And it helps patients if you go home with a record of what happened. You have something you can read, follow up, and maybe take to another physician.
Cheryl, we've got 2 minutes left, roughly. And I want to talk about something that I know you're very passionate about, and that is, tell us what you and your family did last summer.
So I would start off by saying my family's like every other family. When we get together, we eat. And
That's a fair statement, okay.
we cook together. We have fun with our food, I would say. And I think for us, we got to the realization that we have teenagers now, and we'd really like them to not only enjoy great food being cooked by mom, but also know how to prepare some of those meals. And we took the meals that we've loved for years and actually put together a cookbook, which I'm going to hold up here for you. And I will tell you, this cookbook has a number of great aspects. I have a sous chef who's now only 15, but actually did most of this cooking when he was 13.
Wow.
And I tell everyone, even teenagers can make great rice and seafood paella because we were able to do that. But it's also healthy. Charlie mentioned I'm president of the American Heart Association, Founders Affiliate, and one of the things that we're focused on is childhood obesity. And we've got to let people know you can prepare healthy foods, you can make them fun to do, they're not taxing. And this book really does that. We call it Everyone Eats because everyone eats.
Cheryl, you are extremely modest, and just for our viewers to know, this, by being the president of this Founders Affiliate, essentially you are the ranking volunteer between about New Jersey and New England. Having said that, our viewers may be interested in knowing what you and your family do from time to time in terms of what do you do for the community with the food?
So my children volunteer at our food kitchen locally, and my son is actually the head chef.
That is awesome. At what age?
He started when he was 13.
That's
he's
awesome.
15 now, and so everyone can get involved. I think, life, if you've found what you like doing and you can get groups of people to do it, it's
Follow
all the
your
better.
passions. Cheryl, thank you. Kimon, thank you.
My pleasure.
And I want to thank our viewers for tuning in, and I want to remind our viewers, our guest next time will be Peg Calvario from Empowerment Partner. And as always, your money matters. Good night.